Picture this: a perfect electrode, millimeter accuracy, satisfactory imaging, successful surgery. And 3 months later, your patient is worse than before. What went wrong? Nothing in the operating theater. Everything went wrong long before you ever picked up the knife. Tonight, in episode 5, we fix that. Listen carefully. Successful DBS has 3 big steps. Choose the target, place the lead, program the device. All 3 matter, but here is what nobody tells you in residency. Programming can be adjusted afterwards. A misplaced lead can sometimes be revised. But the target choice, that is the only step you can't rescue after surgery. A perfectly placed electrode in the wrong target, in the wrong patient, is still a failure. This is why more than 30% of DBS failures come back to a single mistake: wrong diagnosis or wrong indication. Decisions made in a clinic chair, not in the operating theater. The most important DBS decision happens long before you ever scrub. That is where we start today. So here is the framework I invented to help me choose the appropriate target for my Parkinson's patient. I call it TARGET. 6 letters, 6 questions. To choose the target. T is for true diagnosis. Is this really idiopathic Parkinson's disease? A is for anatomy of symptoms. What are the main leading symptoms of the patient? R is for response to levodopa. Does the medication actually work? G is for goal. What does the patient want? And what is the contribution of medication side effects in the current situation? E is for evaluation of the brain, cognition and mood. And the last T is for the red lines. Are there absolute reasons not to operate? Target is a series of gates. Run target on every Parkinson's patient. By the time you reach the final T, the target has usually chosen itself. And one promise. This same framework returns in episode 6 for dystonia and episode 7 for essential tremor. Learn it once, use it many times. T is for true diagnosis. The first gate, the most important one, because Parkinson's disease has atypical types: progressive supranuclear palsy, multiple system atrophy, dementia with Lewy bodies, corticobasal degeneration. These diseases look like Parkinson's in the early years, but they do not respond to DBS at all. You can put a perfect lead in a perfect target, and the patient will not get better. Some of them get worse, faster. Look at this. STN or GPI stimulation in MSA may show a small early improvement, and then severe deterioration in speech, gait, and swallowing. That is a tragedy you do not want for your patient. So, how do you spot that? 3 red flags: rapid progression, severe disability inside 5 years from onset, early postural instability, falls, or autonomic problems in the first 2 years, bulbar dysfunction, or supranuclear gaze palsy. If you see any of these, stop. Re-evaluate your diagnosis. A wrong diagnosis is a permanent failure. A is for anatomy of symptoms. And I want you to ask your patient one of the most useful questions in the entire clinic. Describe the worst hour of your worst day. What is happening? Listen carefully. The answer points to your target. If the patient describes off time, fluctuations, and peak dose dyskinesias on top, the full Parkinson's spectrum, you are looking at STN or GPI. If the patient describes mostly dyskinesias with a good on state otherwise preserved, lean toward GPI. If the patient describes an isolated drug refractory tremor and the rest is manageable, that is a VIM patient. But here's the warning. This is the one you must not miss. If the patient describes falls, trouble swallowing, freezing of gait, that no medication helps, those are levodopa-resistant axial symptoms. And honestly, no DBS target reliably fixes them. So memorize this shortcut. The dominant symptom chooses the target. R is for response to levodopa. A levodopa challenge test is a test used to measure motor improvement after administering a suprathreshold dose of levodopa. DBS is a biological amplifier. If the baseline signal, the levodopa response, is low, there's nothing for DBS to amplify. This is the single best predictor of outcome we have. How do you measure it properly? 3 steps. 1. 12-hour overnight medication washout. 2. Administer the patient's usual first morning dose. 3. Video or examine both the off state and the on state. Document the UPDRS score in both. Now read the result. If you see 30% improvement or more, that patient is a strong STN or GPI candidate. If only the tremor improves but the global score barely moves, VIM is still on the table. If nothing changes, reconsider the diagnosis. You are probably looking at atypical Parkinsonism, and we already know what that means. G is for goal, and G has 2 parts: patient priority and medication strategy. Part 1. Ask the patient. If the operation works perfectly, what does your life look like? Part 2. Ask yourself, what is my medication plan after surgery? Do the side effects from medications play a significant role in patient suffering? 3 scenarios, 3 targets. Scenario 1. Patient says, fewer pills, less off time. And clinically, you need to reduce the levodopa dose, maybe because of impulse control problems, dopamine dysregulation syndrome, hallucinations, or just a very high dose. STN is your target. STN reduces the levodopa requirement by 30 to 50%. Scenario 2. Patient says, stop the wild movements, but keep my medication, it actually works, and you cannot afford to lower the dose. GPI is your target. GPI directly reduces dyskinesias and keeps the medication neutral. Scenario 3. The patient says, just stop the tremor. The medication is tolerable. VIM is your target. Levodopa stays where it is. The patient's goal and your medication plan must point to the same target. E is for evaluation of the brain, cognition, and mood. We use MoCA test, the Montreal Cognitive Assessment. Think of it as a dial with 3 zones: cognitively intact and stable mood, which we can say robust brain when MoCA is above or equal 26. Either STN or GPI is reasonable. Use the other letters to decide. Borderline cognitive profile, or significant depression or anxiety, which we can say fragile when MoCA tests between 21 and 25. DBS is still possible, but lean toward GPI. GPI carries a more forgiving cognitive and mood profile than STN. Danger: MoCA below 21, or active psychosis. Do not proceed. The risk of permanent harm outweighs anything stimulation can offer. Memorize this rule. A fragile brain does not tolerate STN well. Tilt toward GPI. And remember, dementia is a contraindication. Now, let me zoom out for a moment. Target gives you the clinical reasoning framework. You cannot run Target on a patient you have not properly evaluated. Data has to come from somewhere. That somewhere is the multidisciplinary team, 5 evaluations. Every patient, every time. 1. Neurological. Confirm the diagnosis. Document UPDRS improvement score after levodopa challenge test. 2. Neurosurgical. Confirm surgical candidacy. Discuss the real risks. Manage expectations. 3. Neuropsychological, memory, executive function, plus a psychiatric screen for depression, psychosis, and impulse control disorders. 4. Neuroimaging, MRI to rule out structural lesions or significant atrophy. Data scan if the diagnosis is uncertain. 5. Medical clearance, coagulation, blood pressure, blood thinning medications. Now let me show you how the equation actually solves. 3 patients, 3 targets. Patient 1, the classic STN candidate. T, confirmed idiopathic Parkinson's disease. A, fluctuations of time, the full spectrum of Parkinson's symptoms on display. R, at least 30% improvement from off to on the UPDRS score. G, wants fewer tablets and clinically you need to reduce the levodopa dose. E, robust. MoCA 26 or above. Mood stable, every letter clears. No red lines. Equation solves to STN. What STN delivers: sustained improvement in tremor and rigidity in the off-off state. Levodopa reduction of 30 to 50%. Indirect improvement of dyskinesias from the dose drop itself. That is the classic STN profile. Memorize it. Patient 2, the GPI candidate. T, confirmed idiopathic Parkinson's disease. A, dyskinesias dominating the disability. The on state otherwise preserved. R, a good responder. The on state is already functional. Levodopa is doing its job. G, needs the medication preserved. Cannot tolerate a dose reduction. E, fragile. MoCA between 21 and 25. Or significant depression or anxiety. Every letter clears. No red lines. Equation solves to GPI. What GPI delivers: direct reduction of on-state dyskinesias. This is its strongest, most lasting effect. It does not significantly reduce the levodopa dose, which is exactly what you wanted. And the cognitive and mood profile is more forgiving than STN. This is your GPI patient. Patient 3, the VIM candidate. T, confirmed Parkinson's tremor dominant subtype. A, isolated medication refractory tremor. Rigidity and off time are mild and acceptable on medication. R, tremor is partially levodopa responsive. Other symptoms are adequately controlled. The patient says, just stop the tremor. Medication plan is essentially neutral. A, less central here. Cognitive risk with VIM is lower than with STN or GPI. Every letter clears. No red lines. Equation solves to VIM. What VIM delivers: 88% of patients get complete or near complete tremor relief from 6 months out to 8 years post-op. But, and this matters, VIM does not reliably help rigidity, bradykinesia, or dyskinesias. It is a precise tool for a precise problem. You need to be clear with the patient's expectations here. Now, the timing question. When do we operate? 2 principles. Do not wait too long, but do not operate too early. Both extremes are not recommended. Walk along this timeline with me. Less than 5 years from symptom onset with severe disability already. Stop. That is too fast for typical Parkinson's. Investigate for atypical Parkinsonism first. Around 7 years, this is where the early STEM trial showed superior quality of life with DBS compared to best medical therapy. The lesson: do not wait until the patient is destroyed before referring. 11 to 14 years. The average duration at which most patients reach DBS surgery today. The disease is established. Fluctuations are clear. The equation is easier to run. Above 70 years of age or with advanced disease and severe cognitive decline, risk starts to exceed benefit. But age alone is not a contraindication. If the patient is highly disabled but cognitively intact, individualize. Often lean toward GPI or unilateral VIM. Do not wait too long. Do not operate too early. The final T, the red lines. This is the gate where the whole equation collapses to zero. 6 absolute red lines. Memorize them. 1. Atypical Parkinsonism, DBS is ineffective, sometimes harmful. 2. Dementia with MoCA below 21. Permanent cognitive decline outweighs any motor benefit. 3. Active psychosis. Post-STN suicide rates have been reported between 0.5% and nearly 3%. This is not theoretical. 4. No meaningful levodopa response. There is no signal for the amplifier to work with. 5. Dominant levodopas resistant axial symptoms. False. Freezing. Swallowing trouble. No target reliably helps. Thick coagulopathy. Surgical and bleeding risk too high. Now, here is a hard thing to do as a young surgeon. Saying no. Saying, I am sorry, but DBS is not the answer for you. Remember, confident no protects the patient far more than a hesitant yes. This is the master matrix. Run target. Read across the rows. T. True diagnosis. Idiopathic Parkinson's confirmed. Required for all 3 targets. A. Anatomy. Off and fluctuations leans STN. Dyskinesia focus leans GPI. Tremor only leans VIM, or levodopa response. 30% or more required for STN and GPI. Partial response is acceptable for VIM. G, goal and medication plan. STN reduces levodopa equivalent daily dose. GPI is neutral. VIM is neutral. E, brain status. STN requires a cognitively intact and stable mood. GPI tolerates a borderline cognitive profile. VIM is forgiving across the board. T, red lines. All cleared. That is the equation. That is the framework. That is how you choose. You are not picking your favorite target. You are running target and letting this patient's own equation tell you the answer.